Now we're recording this webinar. I almost forgot again. We are recording this webinar, and we'll put it up on our YouTube page so you can view that after the fact. And that's about all the housekeeping I have. Oh, and also, if you're interested in earning a CEU, just make sure you stay till the very end, and then I'll give you some more instructions on how to get that. So without further ado, I'm going to turn it over to Dr. Farst.
Thank you, Anna Kate. And now that you said the CEU thing, I have to confess to you that I did not put the CEU slide in. So
that's okay. We'll just say it verbally, and it'll work.
Yeah. At the end, whenever it's appropriate. Okay. So thank you all for joining us over the noon hour. You probably saw me kind of trying to sneak in my egg bites. I know everybody is busy, especially as we all try to recover from the spring break time. So the presentation, I don't know if the title, I guess I'm probably surprised that as many people showed up. This really isn't going to be necessarily a geeky medical talk about how to diagnose abuse per se, but I do want you guys, I'm thinking of the audience from an RBEST standpoint and just how I've interacted with you all, that there's probably a few medical people, but there's probably a lot more mental health advocates, different people that encounter kids that have maltreatment issues along the way. So I know some of you will see kids that have this as their history, but also you may see kids that either disclose to you or come in for a session and you see something. So we want to, try to help people understand like when to be concerned, when to not. But I also do just want you to have a little bit of background of the physical findings, because I know a lot of you deal with cases where you're trying to help the caregiver kind of understand protection, safety, all those different types of things. So so there will be some case pictures. I hope there's not anything kind of too traumatizing, but I did just want to give you some visuals. But please do type into the QA as we go along, because I'm here. I want this to hopefully be helpful for you guys. So please type in information that you want us to kind of cover or address. So I'm going to focus on physical abuse and sexual abuse. We're not going to really spend time on the medical evaluation, neglect, or drug exposure. But a lot of times just in my role, I get sent pictures or asked to like look at x-rays, and people just kind of want me to look at something visually and say, hey, is this abuse or not? And so these are, just kind of a variety of examples of the things that we get sent. And I wish I was smart enough to be able to just kind of look at the picture and say, yes or no. But really, with like anything in medicine or mental health care, you really kind of have to have a little bit more context. So there needs to be some history about, well, what do we think happened? What's the history? Is this child medically healthy? Do they have other medical issues that might be causing this? So the answer really in all of these, even in the fracture of the arm bone, is I don't really know. It could be abuse. It could be something medical. It could be an accident. So there really kind of has to be more context to it. So when we're thinking about true physical abuse, so when I am asked to look at something and say, hey, does this look like it's abuse or not? The kind of the three big things for a skin injury is really the age of the patient, and more specifically, the developmental ability of the patient, the location. So where are the injuries located? And then is there a pattern or not? So does it look like a specific implement? This is just kind of a diagram. And for us, there is a kind of a really big difference. And for those of you that work with kids, that once you become ambulatory, kids can do a lot of strange things. So, they can get up on top of their bunk bed and fall, and they can do all sorts of different things to get accidental injuries. But there's obviously a big kind of cutoff or differential between when you're an infant and you really can't do anything on your own, and then when you're just kind of pre-mobile, so you're starting to cruise a little bit, but you're not like a climber, you're not outside riding a horse, that type of thing. So there's really a big difference between the type of accidental injuries that we see in young kids versus older kids. So that's really what age means, that when we see kids that have bruises, and again, especially very young children, in the places where you're just not going to like get a bruise from getting bumped, from just routine kind of household care types of things. So it's a lot of what you think of as the fleshy parts of your body. So the fleshy parts of your cheek, your neck, your abdomen, your butt, the kind of fleshy parts of your thigh. So in young kids, when we see bruises there, those are kind of big red flags, because those are hard places to injure just from, again, kind of routine little bumps or household types of events. The other kind of important thing especially from the medical side, is that when we're seeing a kid, it really is important to kind of look head to toe. Some of you won't have that opportunity. It wouldn't be appropriate for you to do like a naked exam. But at the same time, those are the types of things that, sometimes you might have to advocate with a caregiver, or just be aware that when there is a concern about an injury in one part of the body, it really is important that they get kind of looked at. That picture is a bruise that's behind this young child's ear, and you really couldn't see it until you kind of folded the ear forward. So inside of the mouth is another important part for us to look as well. So what the child can kind of do developmentally and where the injury is located on the body is important. So here are just some kind of real life pictures. So again, when we're seeing stuff on the trunk or on the abdomen, they've got some bruises on the buttocks, on the penis, along the torso. So you can't necessarily see the age of all these kids. I think you can see on the top right picture that looks like it's a pretty young kid that has a bruise on the cheek. But these are all just, kind of, number one, some of them are excessive bruises, but also just the places where they are. They aren't the typical places where you would kind of fall and contact on your elbows, your shins. So the places that we would usually see bruises on a really active toddler, or somebody that is kind of a clumsy early walker. In our field, there's a kind of a mnemonic or a catchphrase that's come out of the research as far as looking at kids that present for medical care, and just really kind of looking at their bruises no matter what they come in for. And there is like a statistically significant pattern difference between accidental bruises and abusive bruises. And that was this research project that came out of Lurie Children's in Chicago, and has come up with a mnemonic. The mnemonic's a little bit clunky when you first start saying it, but then it seems to kind of catch on. But so it's 10-4, for those of you that are old enough to remember CB days in a truck. So 10-4, and then faces with a little p. So let's kind of break that down a little bit. And there's, I should have told you, if you want a copy of the slides that have the links and things, just feel free to email me. I'm happy to send that out to you. But this is actually really accessible on the internet as well. If you Google 10-4 faces P and even put in Lurie for Lurie Children's Hospital. But so the 10, kind of the big TEN, are bruises on your torso, your ears, or your neck. And that's really one that kind of goes across age range. So those are really unusual places, even for older kids, that have bruises. Now, again, if you're bucked off of your horse or something like that, where there is a very significant accident, you certainly can get accidental bruises there. But these are just kind of unusual places for bruises. If you put that into a young child that's not walking yet, they're very, very unusual. Then the other kind of more maybe detailed or specific places is what the faces, the FACES, comes from. And so it actually, the thing that kind of misleads people, even in our ER, is that faces doesn't mean just any bruises on the face. Faces means your frenulum. So it's that little piece of skin that holds your lip to your gums inside of your mouth. The angle of your jaw, so kind of along the edge of your jaw, the fleshy part of your cheek, your eyelids, and then the conjunctiva. So the conjunctiva is kind of the white area that a lot of us call the sclera. The conjunctiva is the kind of white part of the eye. And then the 4 part of that is kind of the age differential. So 4 months and younger, it's really any bruise whatsoever. But then it's really kind of 4 years and younger, this set of mnemonic, but that's kind of what went together to be statistically significant in the study. But I would tell you, if you had like a patterned injury on an older child, that wouldn't mean that it wasn't abuse. But this is really meant to kind of help us think about what injuries are concerning in preverbal kids. Because once kids get older, then obviously they have a little bit better ability to tell us about what may have caused an injury. And so then the little p that's at the very end of the faces is for patterned. And I'll show you a couple of pictures of pattern injury, but that usually means like a looped cord or like a belt. So some kind of implement that would have caused the injury. So 10-4, faces P, it's a mouthful. But it's, to me, it's a little bit more visual of thinking about kind of where on the body are the high risk areas. And then thinking about any bruise under 4, this kind of mnemonic of bruises under 4 years old, and then any kind of pattern injury. If you want to know more about this, there's actually a really nice video in that link from the study author, who's an emergency medicine physician at Lurie, very engaging speaker too. So feel free to check that out if you want some more information. So for pattern injuries, we're talking about the child has been struck by something that leaves an injury. And this is certainly, even from a non-medical standpoint, if you are mental health, if you're in the school advocate, you may see these types of things because they can be present on kids, especially if it's summertime and they don't have clothing down on their arms or stuff like that. The top picture where those parallel lines are is a fairly classic pattern for a slap mark. So the little parallel lines are actually the area between somebody's fingers when they would contact the edge of the face. And that's where the blood is kind of pushed to with the contact. So a lot of times people will say, oh, they fell down and just kind of hit something with that pattern. And that's pretty uncommon if you can kind of even get the hint that that long parallel line extends down to where the fleshy part of the cheek starts. And so that would be really uncommon for a child to just kind of have a fall or an impact onto something to give that type of pattern. The picture in the bottom right is one of the most common patterns that we see is when a cord is looped over. That could be an extension cord, a phone charger cord. And the thing that you can really tell about that is that it does kind of arc around or follow the curve of the body. So you would know that it was a flexible object. If it was a rigid object, or again, if they had fallen on something that was static, it wouldn't follow around the curve of the body. So again, you may see that on a kiddo that's in shorts when they come in, or you might see it on an arm. But we actually do see quite a few kids that are reported from school or from a therapist office because they are able to see that the child has a pattern injury there. And then just a little word about bruise colors. Back when I was in medical school, which was a little bit ago, we used to kind of have a chart that would say that bruises that were red were fresh, purple, gray was kind of about a week, and then if it was yellow, that meant that it was older than a week. And really, as there's been more kind of research work done in this field, we know that actually there's not a lot of rhyme or reason to the colors and when they come up. So obviously, if the skin is torn and there's bleeding, then that would mean that there was a recent injury. And if you do see somebody kind of right after an injury occurs, it may just look red until bruising starts to set in. But the kiddo in this picture was a witnessed event where he was accidentally hit in the eye. And if you can tell off of your screen, there's actually yellow, green, purple, red, a little bit of gray. So all of those colors are kind of mixed into one bruise that happened with one event. So it is difficult from a medical standpoint to try to date bruises or to say that the bruises are of different ages, which can obviously be a big deal if we're talking about trying to figure out where a child was injured, especially if there's split household and kid goes around a lot of different caregivers. So just I would tell you probably not pay a lot of attention to bruise color, other than just kind of describing what you see. And then not all dark spots are bruises. I think most people are probably familiar with the kind of the slang term for the kind of darker color, especially on people that have darker pigment in their skin, called Mongolian spots. The big medical word for that is dermal melanocytosis. And it really just means that there's areas where there's more pigment in the skin. It's usually focused around the buttocks area, but you can see in that baby that's standing up, all of those different kind of dark areas, all of that is Mongolian spot. It can be difficult to differentiate from bruising if you don't know the child and don't know what things look like, but hopefully the parent is able to give some hint on that. If we don't know for sure, then sometimes we just have to follow it for a couple of days and see if it does change. Because if it's bruising, then it should change. But if it's something that they were born with, then it should kind of stay still as well. And then the other, this is my shout out to all the great nurses in the world, because this kid came in and she was actually like 4 or 5. So she was old enough to kind of say what happened. And she had been at her dad's house for the weekend. Mom picked her up. And then when mom took her home to change clothes, she noticed all this stuff and she was like, oh my gosh, my child's been hurt. So she brought her straight to the ER. And so, yeah, everybody was pretty worked up because of all this, kind of bruise looking stuff on her neck and her shoulder. And a very astute nurse grabbed like basically kind of an alcohol wipe or an alcohol pad and rubbed it all off because it was all ink. She had been, I don't know, playing something somehow and got wet, but also had a marker. And so it was actually all just dye that marked off of there. So I think it's always an easy thing for me to kind of take a little alcohol wipe and rub and just make sure that the mark doesn't come off to make sure I'm not missing a mimic that's there. So when will we be concerned? And so when, from your standpoint, would you feel like you would have to put on your mandated reporter hat and make a report? So, if there is an injury and there's just not kind of a plausible or what you might think of as a credible history for how that occurred, then that's what in the Arkansas child maltreatment language, they say that the finding is at variance with the history. So that would be one reason. If there's just not a history that is credible, but also it continues to change. So if you say, well, they fell out down the stairs, and then you ask again, and they're like, well, yeah, they were tussling with their siblings. Now, it may be that there's just a lot going on in the household and a lot of different things that have happened. But if you do have a specific injury, especially like a cord or a loop mark, and you don't have a kind of a specific and credible history, then that should raise your concern too. I think we've kind of talked about that third bullet. The last bullet is probably one to spend just a minute on, because this is, I think the worry that we have a lot of times in a busy ER or in a busy clinic is that it's easy to be suspicious when things aren't really going well with the family anyway. And I think it's easy to miss a red flag that might be there if it's a family that you might think has it all together and are presenting well. So we try to, especially as we're teaching our medical students and residents and people like that, we try to get people to focus kind of on what the objective stuff is. So if there's an injury, what's the history? If it's a pattern mark or that type of thing, it's hard not to let bias come in there. I think especially just because we do oftentimes see injuries and things happen in homes where there is a lot of chaos, or we know that there's been a history of abuse in that family before, and so it's kind of easy for us to tip into that. But I think this is very well established in the literature that people who are disadvantaged, either from poverty or color or really kind of whatever, are definitely more likely to be kind of worked up, meaning that there's a suspicion of an injury, and so they get a more of an evaluation, and they're more likely to be reported to the hotline as well. So it is just one of those. From my standpoint, it's a thing to reflect on my own bias and even my implicit bias that I might not even realize that I'm exerting in there, and trying to hold fast to some more objective indicators when I can. This is one the case that I picked just because I think this is one, especially for all of you mental health or school-based people, that you could come in contact with. So this is a 16-year-old girl, and she showed up at school with this rash on her face. And so her teacher just asked her, because it looked very different, looked kind of odd. And she said that she got in trouble at home, and her dad put her in a chokehold, or sorry, her stepdad put her in a chokehold. And she said it was a really tough chokehold and she had trouble breathing. And so she stopped struggling so that he would let go. And then she said that today her side of her neck is okay, or sorry, the side of her neck was kind of sore, but that she otherwise kind of seemed to be feeling okay. So I think from the teacher standpoint, she was actually very astute to know that whether or not the child had the injuries or not, what the child had described is actually maltreatment or physical abuse. So the chokehold impaired the child's breathing. So that in and of itself, whether or not you saw injuries, would be something that would be reportable. But then on top of that, this child actually did have this rash, which is actually petechiae, which is a special type of bruising where the itty bitty little blood vessels called the capillaries will burst underneath of the skin. And that happens when there's like an increase in pressure, like a valsalva. So if you think about coughing really hard or vomiting or even straining to have a bowel movement. So those types of things can cause petechiae, but then obviously trying to breathe against a blocked airway can cause that too. So this case is fairly dramatic because she's just kind of showered with petechiae on her face. But you definitely can see this in kids. So I don't want you to think that petechiae means abuse all the time. So you certainly can see this in kids that have had like a vomiting illness or a coughing illness. But it was I think a nice catch on this teacher's part just to kind of ask, because this looked odd, and then to be able to make a report so that there could be intervention. So you certainly can, from a strangulation standpoint. I mean, yes, he let her go before she passed out, but you certainly can have a strangulation event to the point that you have like a lack of oxygen injury or even a death. This is what she looked like the next day. So it was reported on that day that I showed you the picture. And then this is what it looked like the next day when she was at a local children's advocacy center for an interview. So it has resolved quite a bit. So it's not as pronounced, but you can still see the petechiae kind of concentrated around her eyes, up on her eyelids. And then if you notice under her neck, you can actually kind of see where the petechiae are under her chin and come down to about the mid neck, but then they're not on the lower part of the neck. And so it really actually goes along with the fact that she kind of described this forearm hold around her neck. And that was kind of the dividing line between that. So from from a system standpoint on that, this is, like I said, it's something that should be reported for intervention. And a lot of times in these, it's the parent is saying, well, she has behavior issues, and so this is the only way I can control her. Well, yes, but if you use that type of physical corporal punishment against somebody with a behavior issue, you're just going to be left with more behavior issues, which I know I'm speaking to the choir now, because that's what a lot of you guys deal with on a regular basis. But that is from an injury prevention standpoint, it's another episode like this could actually cause permanent injury on her. But also, if this dynamic continues, it just further worsens her behavior, obviously can impact with her, just all of her social, school, all of the things that adverse childhood experiences can kind of pile up on and do. So I think it is again, a kudo to the teacher that asked and got it reported so that they could try to turn that in a little better direction. This is just another little link on just for a visual as far as some of the things that you might see when there's been a strangulation event. I, again, wouldn't expect you guys to unclothe people, but you can oftentimes see stuff that just really is from the neck up. And it does tend to become more pronounced in the kind of half day to a day after it has occurred. So these kids are oftentimes folks that once they show up the next day or two at school or at their therapy session, that people are noticing findings that are there. This is just another case. Again, this was one that involved school, but could also involve like a counseling or a therapy appointment. This is an 11-year-old, and he has a mild learning disability, but he showed up with this bruise on his ear. It's kind of not really pronounced, but people that see him every day knew that was something that was new. So when they just asked him, his first response was that he got paddled because he was in trouble, and that he got grabbed by his ear. So those are things that being grabbed by the ear would be something that would cause that type of injury. And if you remember kind of our little 10-4 visual, that's a part of the body that we don't usually see bruises from, just from accidental events. And so it is one that should kind of raise a red flag. So school did the right thing, made the report. And so then when the investigators went out and talked to the parents said, oh, no, he was mistaken. He actually was in his socks and he was running on the kitchen floor and lost his traction and he fell. So that's where they're saying that he got the bruise to his ear. But they do say that, yes, they did spank him with a flat piece of wood on his buttocks. And so that was the day that the school made the report. Investigator goes out and initiates. He stays at home that night with his family, and then he goes in the next day for his forensic interview. And during the forensic interview, he reels back in all that stuff that he says at school, and he said that he actually fell, and that's what hurt his ear and his buttocks. And he says, "Oh no, none of that ever happens at home." So this picture is what the school nurse took that day that it was reported, and so there was kind of good documentation, and you can see the bruising is on his butt, but it's also down on the posterior aspect of his thigh as well. So these are unfortunately, they happen more often than not, because I don't know that folks see these injuries. So when the system responds, he doesn't seem to have a broken bone. He's otherwise looks okay. He just kind of has some bruising. So there's not like this immediacy to try to intervene, or it's like, oh, this can wait till tomorrow type of thing. But if you leave this kind of kid, and again, probably speaking more to the choir with the group of this webinar, if you leave this child in the home where he knows that he now has gotten people in trouble in his family, and so he's able to kind of process some of that, but then also likely is kind of flat out told by his family that if anybody else talks to you about this, you don't need to say that you were injured. So now when he does kind of his formal interview and he recants, A, I'm not surprised that he did, but B, it makes it hard to kind of go forward on making a true finding from the investigation standpoint. Now, from the DHS standpoint, there is and was enough in this to say that was excessive spanking by far. Like, so using a board and leaving those kind of bruises is beyond our Arkansas definition of not leaving more than a transient mark if you do use spanking for corporal punishment. So again, it's a little bit of the same conversation that we had about the girl with the chokehold, that this is a super important part of this kid's life to try to intervene and turn away from corporal punishment. So that message is obviously variably received by people in this type of case, would obviously want to know if there's any domestic violence between between stepdad and mom, because mom really needs to kind of step in and be his advocate. He has a learning disability, so he's even more vulnerable. So using corporal punishment on him is not going to get to the behavior change that the family wants. It's just going to lead to more and more episodes of conflict. So this it's a frustrating scenario. I'm sure many of you have been involved in similar scenarios where there's not necessarily enough to take the kid into foster care, but something has to change in this kid's life, and you kind of hope that with intervention, with some parenting classes, with just the presence of DHS in the family's life, that hopefully things can kind of turn a bit to where this kid gets more obviously developmentally and behaviorally appropriate kind of discipline and behavior modification at home. So I'm going to just go really quickly through burns and then head trauma. I know these are probably not injuries that you're going to see as much, but you may be taking care of kids that have had this happen to them. And I'm going to talk just a little bit about cigarette burns, because that's always a big question. Kind of similar as we're talked about bruises for burns. Accidental burns just kind of tend to look more random. They do tend to happen on older kids who are able to like pull things over on themselves or spill things when they pull it out of the microwave. Abusive burns do tend to be more on younger kids, where they just don't have the developmental ability to cause the injury to them. One of the big issues in burns is it looks like the child was kind of held in one position, and they have more of a well-demarcated distribution of burns versus just kind of a random like splash that would happen. So the picture on the right is a picture of you can almost kind of see it looks like socks, that there's a very well demarcated line between where the burn skin stops and the unburned skin is. So that would indicate that the kid's legs were kind of held in one position. Whereas the other picture is just this kind of random like splash, where some of the skin's burned, some is not. So it's not always, it's typically not that easy to tell the difference between accidental and abusive burns, but that's just an example of kind of the pattern stuff that we might see. For burns where kids are held in place, we can sometimes kind of see like, like where the level of the liquid was and that type of thing. But like any other type of abuse, it's always more difficult when this has occurred in kids that are pre-verbal, because then we don't really get a lot of history to go on, and it's hard to be able to kind of say for sure what happened. We do get, if you remember that very first slide, we do get a lot of pictures sent to us about kind of circle injuries on the body, because it's definitely warranted to be concerned about cigarette burns, because for whatever reason, that is a way that people will inflict punishment, kind of, I guess, just like spanking, because it is something that hurts. For cigarette burns, it's hard to diagnose them without a history that somebody saw it or that the child's old enough to say it. But what we would look for is very uniform sizes. So, a cigarette should kind of leave the same size. And then like that top picture, sometimes we'll see them almost kind of like in a row or in a cluster when that was occurring. That bottom picture is actually a lighter. So the old timey, I guess some of the cars still have them, lighter that you would kind of push in and it would get hot. So that leaves a little bit of a different pattern type of thing too. I would tell you though that most of the pictures that we get sent of circle injuries, I can't really tell if it's a cigarette burn or not, or I can tell that it looks like it's actually a medical thing that's causing the round lesion. So ringworm is a fungus type of infection of the skin. There's different types of like allergic reactions to antibiotics that'll give you circle lesions. Impetigo can sometimes give you a circular lesion. So there are lots of different things that can give us that. And so a lot of times I'm saying I can't tell for sure if we don't get something that kind of looks that really kind of characteristic and diagnostic. And then the last little part of this before we move on to different topic is fractures and head trauma. So you'll see the common themes again, that accidental fractures are much more common in kids that are up and walking, and especially in toddlers and older, when they start to become more daredevilish and don't have any sense yet that it's not a good idea to go diving off of their bunk bed like Spider-Man or something like that. Fractures for abuse in kids that aren't walking yet, it's really that age group of infants, so kids that really aren't ambulatory, is its own risk factor. So if you see a fracture in a child that's an infant, it in and of itself should make us worried and work kids up. Now, I realize that a lot of you guys probably aren't dealing with kids in infancy per se, that you would pick these up, but I think you probably are working with families where these issues might have arisen. There are some specific types of injuries that are more common with accidents and more common with abuse. So a buckle fracture, a buckle just means that the bone kind of crumples down on itself, like if you've stepped on the top of a Coke can before and the can just kind of crumples down. They aren't very impressive looking fractures, so I circled it on here because they're hard to see. These are the legs of the bone. This is the shin bone, which is the tibia, and then the little bone beside that called the fibula. So this would be a common fracture for a kid that like jumped straight-legged and kind of locked their knees so they didn't cushion their jump type of a thing. And these, you can't necessarily tell for sure that they have it right away. They will kind of maybe act like it's bruised or sprained, but they can usually kind of walk on this because the bone itself is not like separated or broken in two. So sometimes we will get asked to put input on because there is a perceived kind of delay in seeking care. But I put this in just as an example that not all fractures act the same. So a more mild type of, this is still a fracture, but it's a injury where the bone is still all together and it's supported. So that can act a lot different than a fracture where the bone is totally broken in two. So these are x-ray pictures of the femur or the thigh bone. The difference in these two pictures is the one on the right where the kind of the bowling pin balls are is a 3-year-old, and the one on the left is a 6-month-old. So the 3-year-old was at a birthday party at the bowling alley, and somebody was kind of rolling a ball really slow, and he was chasing it down. And, the bowling alleys are kind of slippery anyway. So he caught up with the ball and he tried to put his foot, it's like he was going to try to jump on top of the ball. Anyway, he crumpled into a twisted, kind of a twisted heap and cried out right away. People knew right away that his leg was hurt. Like 20 people saw it happen. And so he was taken to the hospital, but the hospital still reported this for abuse because they described that it was a spiral fracture. And so some people think in their brain that the spiral fracture means that someone has to twist the bone to make it break, and spiral just means that there was some kind of twisting motion when the fracture occurred. So this was a really clear accidental history, nothing to be concerned about from abuse, and that fracture would match it. The 6-month-old was home alone with mom's boyfriend when she went to the store, and when she came back, she noticed that the baby was crying and the thigh was swollen. And he said that a spider had bitten the baby, that he had brushed a spider off of the leg. And she thankfully was concerned about the baby and brought the baby in for care. And the baby had, again, this is the same type of fracture, a spiral, but there's no history that explains this. And so this one was reported, and there was much more to the story as far as the boyfriend being upset that he had been left at home to babysit and got upset. So very similar fractures, but different age kids and different stories as well that made them different. I'm not going to spend a lot of time on this again because this is infants, but again, for those of you working with families where there may have been an abuse event occur, I think it's hard sometimes because there are certain types of fractures like the buccal fractures and like rib fractures that kids can have those, and you can't necessarily tell very easily just by looking from the outside. Like we can really only see these on x-ray. We can't diagnose these just off of the physical exam. So in the reason, especially in younger kids, is that the bones are pretty bendable. They're a little bit kind of flexible. And so when they do have a break, they don't usually break all the way in two, speaking specifically of the ribs. They usually just will kind of have a little crack. And so they're hard to see, but they also stay together. And so it doesn't cause this. If any of you have had a rib fracture as an adult, they are very, very painful. And there's no doubt at all that you have a fracture. But our adult ribs are very different than baby ribs. The best analogy I've been able to think of is a kind of a green limb or a green twig. So the picture on the right, it's kind of hard to tell that there's a break in the twig, but then when you put some pressure on it, you can see that break site. And that's very similar to what we deal with infant rib fractures. So it's always a tough conversation with parents because if they aren't the person that injured the child, then they really kind of don't believe us that the child was injured because they're like, I would know if my child had a fracture. But there are some really unique things about infants and young children that it can actually be difficult to see just from the outside without x-rays that the child has a fracture. And just a couple of little slides on abusive head trauma. So I think in the lay world, so non-medical world, this is still oftentimes referred to as shaken baby syndrome. So meaning injuries that come from a child being violently shaken. So we've already talked about some of this because rib fractures are one of the things that can happen. Really kind of the bigger thing from again, working with a family standpoint is what would have triggered this? So what would get to the point of making somebody kind of so frustrated or so upset that they would shake to the point that there was injury? And the number one trigger for this is crying or colic. So if you're working with a family and maybe you're working with an older child, but you know that there's a baby in the home and there are stressors with the caregiver as far as like behavioral problems with the older child, or you know that it's a parent that is dealing with a substance use disorder, or you know there's domestic violence in the home. So if you hear that, and again, you kind of also get a sense of the fact that maybe this baby is fussy and hard to take care of, these are kind of opportunities to intervene to make sure that people know that crying is normal in babies, but it can certainly drive you to the point of being very, very angry because you feel like you've done everything you can to try to help calm the baby down, and they continue to cry and continue to fuss. So it is really important for parents to know that if a baby's crying to the point that they can start to feel that anxiousness and even anger, that it's okay to set a baby down in a safe place, not on an elevated surface, and walk away and calm down, call somebody, do something. But these are, it's always frustrating. I mean, it's never good from any type of injury with a kid, but these can just be so devastating to the point of permanent brain damage and even death. And it really is just almost kind of like this 10-second period of time where somebody just totally lost their temper. So it is, it's obviously it's hard to be a parent, and even harder if you have more than one to take care of and you don't have a lot of support or other things to kind of help prop you up. This is just another resource as we kind of transition from physical abuse into a little short segment on sexual abuse, that if you do kind of want more information about findings and that type of thing, the National Children's Alliance, which is the accrediting body for the Children's Advocacy Centers, has a nice handout on it. And this, I maybe making an assumption that I shouldn't make, but I think that this group may be more familiar with a lot of the dynamics in sexual abuse than physical abuse. So I may go a little bit quicker through some of the dynamic stuff in this one. But, usually with sexual abuse, the offender is somebody known to the child and to the family. And that's a big part of why there's oftentimes a delay in the child disclosing. And so as we talk about the fact that all of this that we just talked about with physical abuse, where I showed you all of these pictures, there's oftentimes not physical findings. It's very difficult for me just as a medical doctor to be able to do an exam on a child and tell you if they were sexually abused or not. So I'm not going to show you a bunch of pictures in this section, but we are going to talk just a little bit about why there's not oftentimes findings. So when we're doing a medical evaluation for sexual abuse, if we are within the time period that we might be able to collect DNA evidence, which is less than 72 hours, it is important for us to be able to be available, do that quickly, because if we can collect DNA evidence, it obviously helps the investigation with the amount of information that's there. And then we'd also, if there are injuries that are there, we want to document those. And if they have infections, or if we need to provide prevention medication against infections and those types of things. But a lot of the times what we're doing with these exams is somewhat more reassuring the patient and the family that their bodies are still okay, even though something terrible and traumatic has happened to them, and trying to make sure that we can be the biggest cheerleaders for them going and getting assessed for trauma-focused therapy as well. So 72 hours is still usually our time frame for when we are trying to see kids kind of quickly. So if you have a child that discloses to you during a session or just during your work with them, if you're able to kind of know the last time it could have happened, it kind of helps you know how urgent you need to be as far as directing the child kind of for the next step too. If this is something that happened a couple of weeks ago, then there's time to kind of report and let the referrals take place. If this just happened last night, then it may be something that they need to go to the emergency department for. This is a little mnemonic that we use with law enforcement or for investigators. And again, I know just with the work that you do with families, I think there may oftentimes be resistance from a caregiver to say, well, I don't want my especially young girl to go through a pelvic exam, because we would think of kind of our own experience from a gynecology standpoint. But really the type of exam that we do is not like that for child sexual abuse. We don't use the speculum. It's not an invasive type of exam. So it's obviously still awkward just because we're looking at private parts. But we sometimes feel like we don't get the opportunity to kind of do an evaluation on a child so we can get to the point of discussing that your body is okay, even though something bad has happened, because there is kind of this perception that the exam is going to be traumatizing and that there's really not an indication to do one unless we're going to collect a rape kit. So again, we don't use the evil speculum for young girls, and that we usually actually don't even have to use it on teenage girls unless there's kind of a specific indication. So again, I know it's awkward just because we're looking at private parts, but there's nothing painful that we do during the exam. We do just try to get the child relaxed to be able, so that we can just kind of look between the labia majora to be able to see that that area, to be able to look for injury or things that might indicate infection to us. But again, it's not anything from an invasive standpoint. So for those of you that deal specifically with victims of sexual abuse, we do photo documentation of the exams. And I know that can sound funny to folks sometimes that we're like using a camera on kids during the exam, but we do use it because we need magnification to be able to see, but we also do want to be able to capture the images. So if there is something that's going forward from an investigation standpoint, the child doesn't have to go through multiple exams. So we've got the findings captured. So then if somebody wants to challenge it or something like that down the line, we can do that through the images and not have the child go through multiple exams. Just the kind of real brief, and this, hopefully is not necessarily brand new news to this group and to this audience, but the majority of the times that we do exams, we're actually marking that our physical findings are absent. So it's a normal exam, even if the child has made a very, very clear and credible disclosure of sexual abuse. So the reasons why, and this can include kids that have made very clear descriptions of penetration. It can include kids that have had sexually transmitted infections. So the skin in the anal and the genital area is the same type of skin that's on the inside of your mouth. It's very stretchy, elastic skin called mucosa. So number one, it can kind of stretch and accommodate quite a bit, but even if it does get injured, so if it gets a scratch or a tear, if you can think of when you've bitten on the inside of your mouth before, that skin heals really quickly, and it doesn't heal with the same type of scar tissue that we might think of with our regular skin. And I've seen kids before that have had pretty bad injuries when we do get to see them right away, and I can see them back in a couple of weeks and I wouldn't be able to tell that there was an injury there. But one of the bigger parts of this that is, I think, can be really hard for investigators sometimes is the meaning of penetration. So if you're talking to an 8 or especially a young girl, an 8 or 9-year-old that has no concept of what sex would really feel like or what that experience is like, and they're describing it kind of in their developmentally appropriate language, they will say oftentimes that something went in and it hurt during their interview or during their time. And we automatically think that they're talking about like full vaginal penetration intercourse because that's our kind of adult concept of it. But for especially young girls, before they start to go through puberty, the area, the hymen, which is the skin that's around the opening to the vagina, is actually pretty sensitive to touch. And we have to be careful not to touch that when we're doing the exam. So if something goes past the labia majora and contacts the hymen, they're going to say something felt like it was inside me and it hurt. But they're not necessarily saying that something went all the way into the vagina. We spend a lot of time on this from a forensic standpoint with court and investigations, and a lot of times trying to explain to people why you should still believe a child who has disclosed a painful sexual abuse event, even though they don't have physical findings, when it really probably shouldn't be as big of a deal as it is. A lot of times people that use young kids for their sexual gratification, they do that in a way that they aren't going to injure the child because they want to keep that relationship going. If you can think from an anatomy standpoint, and sorry, this might be TMI, but if you think from the anatomy standpoint of a young girl, the labia or the big flaps of skin on the outside are actually, it's a three-dimensional structure. Everything's not in the same plane. So if you think about kind of that Dixie cup that's on its side there, the labia are the kind of the outer edges of the cup. And then there's this kind of space. And then the very bottom of the cup is where the vagina would start. So that's where the hymen is. The hymen's around the opening of the vagina. So you have all of that space that's in there where a lot can occur from a sexual gratification standpoint, but it would never even provide the opportunity to interrupt the hymen because you don't have to go all the way through the bottom of the cup in order for there to be sexual abuse and the physical sensation of what's going on. So again, maybe a little bit TMI, but I think it is super important for folks dealing with kids who have been sexually abused to be very comfortable with the fact that the absence of damage or of scarring or that kind of stuff in no way means that the child has not told the truth. There is this myth in our culture that something has to pop or break or bleed the first time you have sex, and that's actually just not true. It is a myth. You can certainly have, we have experience, and there's information in the literature about even teenagers who are pregnant will still have a normal hymen because it can stretch enough for things to be able to pass through and accommodate. And young kids, but can't get pregnant yet, we can have young kids with STDs, and even those kids will not have definitive evidence of penetration on their exam. So the exam is oftentimes not really to prove if something happened, it's really to make sure that the child's healthy. And to check for infections. If there is information there from a rape kit or an injury, we want to document that. But that's probably honestly less than 10% of our cases. The majority of the time we're talking with family members and kids and investigators about the fact that saying things look normal doesn't mean that the child's not lying, doesn't mean that the child doesn't need protected, doesn't mean that the investigation doesn't need to go forward, and it absolutely doesn't mean that the child doesn't need referred for therapy as well. So it's a tough cultural myth to get past, but also I think important for this audience to know that if you have a family member that says, well, they said something happened, but the doctor exam said it was normal, so it couldn't have happened, that you guys hopefully have a little bit of equipment to know that that's not necessarily true. I'm not going to go into depth on the delay in disclosure part, because again, I think this is probably something that is for this audience, kind of well known and well understood, that it is just as normal for kids to delay and disclose sexual abuse just because of the dynamics that they oftentimes know their offender. They know that it's going to create some issues in the family if they disclose, as it is to have a normal exam. But I see kids get attacked on this quite a bit in court to say if this was really real, they would have told right away. And then, just like the case that we had, if a child does disclose and they are able to see that it created stress in their family and they're left in that situation, then you can also almost want to guarantee that they're going to recant and pull that disclosure back in as well. So, pretty normal or expected types of reactions from just kind of the child perspective. So that was a quick whirlwind. I might have shown you more pictures than you wanted to see. May have talked about things that you didn't want to talk about over lunchtime, but anxious to see if there's some questions or things that I can maybe try to help explain better.
Thank you, Dr. Farst. That was really helpful information, especially for those who work with these children. We did have a few questions come through. One person wanted to know, as a school counselor, are they allowed to take pictures of a child for a DHS report?
Yeah, I think that I would say no if it's private parts. So please don't take pictures of, butts and genital areas. As far as just kind of other parts of the body, I would leave that to your school policies or your, if you're a nurse, then I would say, you have HIPAA issues to deal with, that you can't kind of take stuff that would be identifiable to the child. But it certainly can be helpful to have photo documentation, because as many of you may know, if you make a report that's just for bruising, DHS can have 72 hours to respond. So by the time they respond, the injury might not be visible again. I would tell you the best probable way is to do your hotline report and potentially even do then a local police report, because then the police could come and take pictures and then have it in their system. But I would personally be okay with you guys taking pictures as long as it wasn't of a private part area. But then, again, having some kind of chain where those pictures are kind of labeled and kept within your organization. So it's not just on like your kind of private phone.
Someone else wanted to know if a child goes to the ER for injury, and then is it followed up with, they go to the advocacy center. Do they end up having to tell their story twice? And how do we try to reduce that number of times they tell their story?
Yeah, and some of that does depend on where the child first discloses. So if they walk into the ER and say, I got, hit at home last night, then the ER is usually only going to take enough information that they need to be able to make the report and then to guide the medical care. And then they want to leave the rest of the kind of the details of the investigation up to the folks that respond. So So I would say that, yes, the child would probably have to get talked to twice because of the fact that they have to know enough information to plan their medical care. But as far as trying to do the really in-depth narrative about, who all was who, where did it all happen, how many times did it happen, that more in-depth thing, we as a system should be trying to kind of coordinate so that we aren't duplicating it. And that's a big thing to advocate for in your own community as well, that kids, especially if they disclose at school, don't have to do kind of an in-depth disclosure at school prior to it being reported, because then there does have to be an interview with the investigator. So there are several of the statutes as far as how a case is found true. There has to be a disclosure that's kind of in that more formal setting. And so, yeah, we do. And I think the children's advocacy centers are, I think, trying to kind of help from an education standpoint with the investigators across the state too, so that we can try to help coordinate things and minimize the amount of times that the child has to tell their story.
Mm-hmm. That leads to a similar question about who ultimately decides if abuse occurred. Is that the police, or who makes that determination?
It's a great question, and it kind of depends on what you're asking as far as the diagnosis of abuse. So I can make a medical diagnosis of physical abuse. So if I see a loop mark on a child, whether they kind of tell me or not, I can say that that's an injury that the child wouldn't have inflicted to themselves. And so I've made a medical diagnosis of physical abuse. As far as the system, then the investigators have their own protocol that they have to go through. And so sometimes what I say is enough for them to say, yes, this was physical abuse. But oftentimes they have to have their other kind of criteria that they go through before they can say that they've made a finding. So the kind of the terminology from the DHS or the Crimes Against Children Division is that they've made a finding of maltreatment off of certain criteria. And then that finding can be appealed by the family the offender, if they want to. But then there's the criminal side of whether or not there's enough to press criminal charges. And that even has its own kind of code or criteria for it. So it is confusing, because I've had judges kind of get on me before because I've said, well, my diagnosis was abuse. And the judge is like, well, that's my decision. It's like, yes, sir, that's right. But I'm not making a judge decision. I'm just making a medical diagnosis. So it really kind of does depend on which lens you're looking at it through.
Right. Well, I'm really sorry to everyone else whose questions we weren't able to get to, but I'm glad that you found this presentation helpful. For those of you who need a CEU, the code is 2803. I'll say it one more time. 2803. I will send out an email with a link to a survey, and you can put that code in the survey and you will receive a CEU certificate back by email. And also we can share, I think it's okay with you, Dr. Farst, I can share these slides with the group. And then if you need any more information, feel free to email me, and we can help you with any other questions you have. So.
Yeah, and if we didn't get to your question, my email's on this slide, so feel free to email me if I didn't get to your question. And thank you very much, Anna Kate, for the opportunity to be able to present with your group.
And thank you, Dr. Farst. This was really great, and I hope everyone has a great afternoon, and we'll see you next month for our next webinar. Thank you.
Hey, Anna Kate, are you still there?
Uh-huh.
I am going to send you just a little bit of a scaled down version, just so that I don't send out all the patient pictures.
That's good. Yeah, I think that's better.
I'll send you the slides so that then they will have the links of
The
any of that.
information. Yeah, that's perfect.
I'll do that right now.
Okay, thank you.
Thank you.